collaborative care model integrates the treatment of mild to moderate mental health conditions within primary care. So that really is a collaboration between the primary care physician, the behavioral health care manager, and the psychiatric consultant. There are at this point over 90 randomized controlled clinical trials that show that collaborative care is far more effective than care as usual. There's also really good data that shows that collaborative care can be effective for individuals with more complex mental health needs and in rural areas and for marginalized populations. And so really we've been able to study the collaborative care model in a variety of different diverse populations, and we found that it works. This is the time now where we should say no child should die of mental illness. How do we really think about having our mental health care delivery system be as close to our physical health care delivery system as possible?
Hello and welcome to SMI Spotlight. I'm Dr. Xavier Amador, and I'm very, very excited and happy to have with me Dr. Roshni Koli, who is a psychiatrist. I'm going to let her explain a little bit more about the areas of expertise, but she's also the Chief Medical Officer at the Meadows Mental Health Policy Institute. We're going to be talking about the collaborative care model, and she'll explain what that is, and I'll be asking questions. So welcome, and tell us a little bit more about what kind of psychiatrist you are, because you really are specializing in a way that I rarely run across.
Thank you so much, Dr. Amador. It's so nice to be here with you today, and I am grateful for the opportunity. I specialize in child and adolescent psychiatry and also in perinatal or reproductive psychiatry. When I went to medical school, I had a vision in my mind that I would be a pediatrician and work with kids. I've always loved working with children, but my mom was a dietitian and really instilled upon me just the importance of nutrition and thinking about mothers when we think about pediatric health in general. And so I went to a residency program in Chicago that really specialized and focused on caring for women throughout the lifespan. And then I went on to complete fellowship in child and adolescent psychiatry. So
Wow.
I have been fortunate in my career to be able to do a little bit of both and spend time in women and children's hospitals and really focus on that maternal child health continuum of care.
And on a personal note, you're a mother as well, I discovered before we started.
Yeah, I have two wonderful boys, and they keep me busy and tired and also keep me grounded. I think there's nothing as humbling as being a parent. I realize all the things that I don't know that I'm continually learning every day, but also it's really amazing to have. When we're in the midst of chaos and an unpredictable world, it's really wonderful to come home and to feel anchored and grounded and feel a sense of joy with my boys.
Yeah, my kids definitely ground me, and they do challenge me sometimes. It's not always a sense of joy, but I do get that as well. Let's start off with sort of the obvious question. What is the collaborative care model? Give us a sense of what that is.
So, the collaborative care model is actually an integrated healthcare model that has been around for quite a while now. It is really a way, it's an evidence based model that integrates the treatment of mild to moderate mental health conditions within primary care. So, in its simplest form, it means that when you go to see your primary care physician is supported by a team of a behavioral health care manager and a psychiatric consultant, and they really support that primary care physician to be able to screen and provide early intervention and treatment for mental health conditions.
So the primary care physician has a caseworker, a behavioral health
That's
kind
right.
of specializing, and then also a psychiatrist. Would it be, or
That's
some
right.
other? Really? Wow. And do you find that primary care physicians are open to this kind of? I mean, I've my primary care physician. She's actually great, and she does a lot of mental health screening on her own. But
Mhm.
I'm going to have to ask her after our conversation, would you be open to doing something like this? How do you generate places and situations where this can actually happen?
Yeah, it's a wonderful question. I think more and more, and in the midst of the COVID-19 pandemic, we really saw a rise and an increase in common mental health conditions like
Right.
depression and anxiety. And we found that they were rising to the degree that many individuals were in crisis. And oftentimes that was because of our workforce shortage. They weren't able to get in to see a therapist or a psychiatrist. And so primary care, I think, sort of got burdened with saying we have to do better with mental health care
Mhm.
because our patients are asking for it. And we are now asked and with recommendations to
And and
screen
I
for
and I
depression.
don't have a psychiatrist to refer my
That's
patient
right.
to.
That's
Right.
right. And so I think primary care physicians were really feeling more overwhelmed and under equipped. I think likely if we talk to primary care physicians, depending on when they were trained, they may have had no or very little training in mental health. All of us in medical school, we get a little
6
bit of
weeks.
psychiatry, a little bit of
6 weeks.
surgery, 6 weeks, right? And
Right.
that's not nearly enough. And so the really nice thing about the collaborative care model is the primary care physician doesn't need to feel alone. They have a behavioral health care manager who's embedded within their practice. If someone screens positive for depression or anxiety, they can say, listen, I have a behavioral health care manager right here in my office that can help us with next steps. And then that care manager can speak with a psychiatric consultant, and they basically do a case review every week, and they can get guidance on making sure we have the correct diagnosis and treatment recommendations. And then, if there's a medication to prescribe, the primary care physician can do that, and they can feel more confident because they're getting those recommendations from the psychiatrist. And that
Mhm.
behavioral health care manager is continuing to follow and track symptoms over time.
Mm. Yeah, I wonder, and perhaps you have some experience with this, whether stigma as a barrier to getting mental health treatment is maybe reduced when you get to the mental health care treatment through your primary care physician. Has that been your experience?
It absolutely has. And that's such a wonderful observation. I think far too often, what we've seen is that when a primary care physician refers a patient to a therapist or a psychiatrist in the community, almost 50% of the time, they don't follow through with that referral. And I do think there's an aspect of it that is stigma related. There's
Mhm.
probably also an aspect that's workforce shortage related too,
Right.
but there definitely is a stigma aspect to it. In some of my work with pediatricians, families oftentimes tell me, look, they've known this pediatrician since birth. This is the person they trust for their child's care, and this is who they'd want to go to be able to address all types of health concerns.
Does this model engage caregivers as well? And if so, how does it do it? Because of the HIPAA walls, I call them, not the HIPAA laws, that
That's
that come up
that's
often. So if you're trying to help somebody, for example, that comes into your office, I'm a primary care physician, and somebody comes in and starts talking about the FBI conspiracy against them, and I'm going to talk with my behavioral health specialist and the case manager, and maybe if we're lucky, we get this person to talk, with the mental health side of the team. Um, how do you engage family caregivers? Is that part of the model or no?
It's a good question. And this kind of goes back to as a child and adolescent psychiatrist, I really think about things as a family systems approach.
Mm-hmm.
That engaging family, engaging caregivers is really crucial to ensuring that we have really good treatment and follow up.
Right.
And so, it becomes a little trickier with HIPAA, as you mentioned, and consent as individuals get older. But, with as long as you have those consents and that ability to talk with family and caregivers, they can absolutely be included as part of this collaborative care model. And I think, especially enlisting caregivers, both for their observations of what they're seeing at home with their loved one, they sometimes are more aware of what is happening, sometimes than even patients themselves.
Oh
And
yeah.
so getting that input is so crucial. And then I think thinking about it in the support system. So if we can really, as a primary care physician, talk with patients and say, look, we want to bring your family in just so that they can provide you the support that would be most helpful to you in your healing process. I think that can be a really nice way to invite caregivers and family to come in. And then, absolutely, the behavioral health care manager can work with family and caregivers.
Okay. And if you have a patient that is reluctant to let the family get involved? Is there any kind of engagement strategies that you use? Um,
Yeah. Well, I think I always think about it from a psychiatry standpoint. I always try to think about why don't they want family to get involved or
mhm.
caregivers. So if we can understand what some of those concerns are, what some of those preconceptions may be about having family be involved, then we can start to have a more of a discussion.
Uh-huh.
So I think really just trying to understand where patients are coming from and helping them to understand that bringing family in is really as a way to support them better.
Yeah, I have to tip my hand a little bit, and where I'm going with this particular question, and we don't have to stay on this for long, is um, because my work is primarily with people with SMI, with
Mhm.
schizophrenia, bipolar, schizoaffective disorder, and roughly half do not understand they have mental illness. They're blind to the fact they have the symptom called anosognosia. So I just wonder if there's something about the collaborative care model that maybe helps us reach some of those people who have no awareness whatsoever that they even need mental health care.
I think it's very relevant. And I think it does. I think the collaborative care model, when a primary care physician feels more equipped to care for individuals with mental health needs, then I think it opens the door to more screening and early intervention and
Mhm.
conversations about how you can connect to care. The other nice thing about this model is that it's the only fiscally sustainable model or only model that has designated billing codes.
Oh,
And those billing codes can actually be used for care coordination. So the
that's
time
huge.
that's
That
huge,
is
right?
huge.
If
Yeah,
we think about our mental health system in our care delivery system, one of the things that is really missing is care navigation.
right.
And collaborative care actually allows a way to bill for care coordination. So the time that the behavioral health care manager spends in maybe connecting a patient to community resources or connecting them with a psychiatrist if that's what they need, or really kind of figuring out what do they need to make sure that they're getting the right type of medication and that they were able to fill it at the pharmacy. All of those aspects of care coordination that can be billed for within the collaborative care model.
Wow.
And so, for individuals with more complex mental health needs, while this model is really designed for mild to moderate mental health conditions,
Right. Yeah, I heard you at the beginning say that. Yeah.
right, reasonable for primary care physicians.
Anxiety, depression, eating
That's right.
disorders, et cetera.
Yeah,
Right.
exactly. Sometimes ADHD for kids.
ADHD. Right.
But still, if you have an individual with more complex needs, that collaborative care model could allow for some bridge care or some care coordination to make sure they're getting the right type of care. And
Right.
I think it also brings attention to some of the more complex medical needs that may arise. I mean, we know that for individuals with SMI, they have a shorter life expectancy,
Right.
right? They're dying 10 to 20 years
Right.
earlier than the rest of the population. And it's oftentimes due to the same things that everyone else is dying from, things like cancer and heart disease.
Yeah.
And so, if there's a greater attention sort of focused on that intersection, that holistic care of combining physical health care and mental health care, I think we're overall going to be able to achieve better health care.
Yeah. No, I think that's spot on. Um, what about children? I mean, we have such a shortage of child psychiatrists. It's nice to actually meet one. Does the collaborative care model make access for children getting mental health services better? Yeah.
It
In what
does.
way?
It definitely does. There are at this point over 90 randomized controlled clinical trials that show that collaborative care is far more effective than care as usual. The greatest body of evidence in that is for adults and generally for mild to moderate conditions, but there's also really good data that shows that collaborative care can be effective for individuals with more complex mental health needs and in rural areas and for
Mhm.
marginalized populations. And
Right.
so, really, we've been able to study the collaborative care model in a variety of different diverse populations and diverse geographic areas throughout the country. And we found that it works. Now, for children, there's a little bit less evidence because we've really been studying that more. But the studies that we have are solid and they're evidence based, and it shows that pediatric collaborative care can really act as a workforce extender. We know that there's this huge shortage shortage of child and adolescent psychiatrists. Where I am here in Texas, we have about 11 child psychiatrists per 100,000 children and adolescents. And the reality is that we need about 3 times that many. And so the collaborative care model really can act as a workforce extender. Some colleagues of mine at the Meadows Institute recently published a paper that showed that a psychiatrist could care for up to 8 times as many patients through the collaborative care model than if they were seeing patients individually. Because a psychiatric consultant is providing indirect consultation.
Right.
So they are meeting with the behavioral health care manager about once a week for a couple of hours to go over an entire panel of patients.
Right.
And because they're providing this indirect consultation, it really extends their ability to provide consultation and expertise. The other thing about the collaborative care model is it uses measurement informed care. So you're starting with these validated assessment tools, things like the PHQ-9 or the GAD-7, that we know we can not only use to screen for symptoms, but to track symptom improvement.
Monitor and see
Right?
if
To
treatment
monitor.
is effective. Right.
Exactly. Just the same as we would monitor someone who has high blood pressure. So if
Right.
you go into your doctor and you have high blood pressure, the next time you come in, we're going to track your blood pressure at that time.
Right.
Or if you
Right.
have a history of family history of heart disease, we're going to make sure we check our lipids, and we're going to, maybe try some lifestyle and different modifications. And then we're going to come back and look, what do those lipids look like now? And then really kind of it enables us, these data measurement points allow us to really be able to have the best clinical decision making, because we're going off of these different data points and measurement. And so mental health should be no different, right? And the
No.
nice thing about collaborative care is it really embodies measurement informed care.
Objective measures to screen somebody and then track their progress. Yeah.
Exactly. Yes.
Yeah.
And so that's really what allows a psychiatrist to do more. And
Right.
in the pediatric setting, it's the same. It's really that it's using that exact same model, but it's really meeting the pediatrician where they're at. I can't tell you the number of pediatricians that tell me that they want to care for
Yeah.
an individual's whole health, but they feel like it's a struggle with mental health care because there oftentimes doesn't seem to be the resources within the community. And it's so hard to get access to a child psychiatrist.
Right.
But this collaborative care model allows them access to a child psychiatrist, but they maintain sort of that ownership of that physician-patient relationship and care. In one of the practices that we help support in getting collaborative care up and running, we spoke with a young adolescent who was about 13 years old, and he's living with his grandmother. And he was really struggling in school, and he was experiencing some symptoms of depression in the context of bullying. And they went to their primary care physician, and because they had collaborative care, that primary care physician was able to connect them right with the behavioral health care manager. They were able to track those symptoms with the PHQ-9. They were able to do some brief therapeutic interventions, doing some motivational interviewing, doing some coordination with the school, making sure he had the resources that he needed there, and having some behavioral interventions within school. We talked to him probably about 3 months after the program, and his grandmother shared with us that, had this program not been in place, they had so much else going on in their life that even the thought of calling someone in the community for therapy felt too overwhelming.
Yeah.
And so she just expressed such gratitude because she was able to really see this transformation where she felt like for this period of several months, she felt like her grandson just wasn't himself because he was dealing with some stress and some symptoms of depression. But through the midst of some of these interventions and tracking over time with this collaborative care model, they really saw him come back to himself and to be in a really great place.
So he went to his doctor and he got
Mhm.
treatment for all of who he is, including his
Excellent.
mental health
Yes.
and depression and being bullied in school. It sounds great. How does somebody find a primary care physician that's operating in this model?
It's a wonderful question, and while there isn't, an easy database, we need to really look at these areas. And we've been doing some work and really examining areas in the country where we've seen greater uptake of collaborative care. And we've
Okay.
been really focusing on doing education and creating some technical assistance tools to be able to support some of that implementation. So say that you want to transform an academic health system that may have 50 primary care clinics, then you need to get the buy-in not only of the pediatric primary care physician, but also the health system leaders, maybe the CFO. You really need to really think about that practice transformation, that change transformation. So we've tried to create technical assistance tools that can speak to all individuals who really need to understand the model to be able to commit to making sure that it can be implemented. And there are some upfront costs. And so there are some implementation costs. We did a study looking at the average implementation cost across the country. And
Okay.
while the model is fiscally sustainable, there is an implementation cost that you need to get started. And sometimes some costs related to technical assistance, which we know really improves the overall collaborative care model to fidelity.
And is there data on cost effectiveness over time?
There is. And so some of the older studies have really looked at that there was a savings of 6 to 1 when you implemented the collaborative care model. So some real significant cost savings. Some newer studies out of Pennsylvania have shown that it absolutely breaks even. And, in some of we're working with a partner here in Texas doing pediatric collaborative care. And the child psychiatrist was sharing with me the other day that they were actually tracking how it affected ED visits. And they showed a significant decrease in the number of children and adolescents who went to the emergency room for a behavioral health concern. And so, I think it makes sense, right? Because they're getting, ideally, with the collaborative care model, you're getting care earlier. The average right now is that for a child from the onset of symptoms until the time that they get care, it can be a delay of 8 to 10 years. And so in that time frame, conditions worsen, just like any other health condition would if we didn't get timely treatment.
And the likelihood of response to treatment decreases with
Exactly.
longer durations to first treatment. Where do the behavioral specialist case managers come from? Who are they? How do they get recruited?
Yeah, it's a wonderful question. So, the behavioral health care manager, as the model was designed initially, it does not have to be a licensed individual.
Okay.
Some clinics choose to have a licensed individual because then they have the ability to both provide care through the collaborative care model and then also provide some more traditional therapeutic interventions. But the way that the collaborative care model was designed is that the behavioral health care manager provides these brief therapeutic interventions. They do a thoughtful, comprehensive psychosocial intake, and they manage the registry, which is what we were talking about, those validated assessment tools and tracking that over time. Now, there is a shortage of all mental health clinicians and all workforce across behavioral health. And so, that training for behavioral health care managers really varies right now. We're
Right.
actually in the process of designing some curriculums for behavioral health care managers. There are some nationally available curriculums. They can take anywhere from a few hours to up to 9 or 10 hours to do. And then, as we've really looked at the workforce shortage, we're in the midst of a program and a project right now in which we've partnered with a community college because we
Oh,
know that when with workforce shortages, you really want to be able to grow workforce within local communities. And so if we can we help to design a curriculum for behavioral health care managers for a community college so that when those
wow.
behavioral health care managers get trained, they can then really function in that role within the communities that they already reside in.
So it could be a 2-year degree.
It could, yeah,
Yeah.
it could. And it doesn't have to be, it really can be for an individual who has a bachelor's degree level of training. They could then, just do a little bit more specialized training be a behavioral health care manager. It
Right.
isn't an extensive period. And I think what we oftentimes find is that, I serve as a psychiatric consultant now in a pediatric primary care clinic. I meet with my behavioral health care manager once a week for about an hour or two. And, we talk specifically through each case. And through that, we have that opportunity to have this continuous learning, to
Mhm.
really think about where is this role for some motivational interviewing or some
Mhm.
behavioral activation? What are some brief therapeutic interventions that we can do? And who are the right people to be involved? How do we talk with families? How do we talk with schools? Really kind of thinking about that thoughtful role of care coordination.
That was one of my actually was going to be my next question. Non-pharmacological treatments,
Yes.
psychotherapy. You were talking about motivational interviewing, and I'm thinking about dialectical behavior therapy, cognitive behavioral therapy. Is is access to that increased? And if so, how does that happen? Um, who does that? Is that your job as the psychiatrist?
Oftentimes, so it depends on the level of training of the behavioral health care manager.
Right. Right.
For some behavioral health care managers, if they're trained in CBT or DBT, they may be able to provide those more intensive, manualized therapeutic interventions. For other behavioral health care managers, they may be providing more things like general coping skills and
Okay.
behavioral activation and motivational interviewing. Still, those things in and of themselves can be incredibly helpful.
Mhm.
The role that's incredibly important here, though, is making sure first we have the accurate diagnosis. And so
Right.
that really is a collaboration between the primary care physician, the behavioral health care manager, and the psychiatric consultant, making sure that through the use of the validated assessment tools and the intake from the behavioral health care manager, we've got the right diagnosis. And then
Right.
we can talk about, maybe this individual does need DBT and what would that look like and what's the right referral into the community. The nice thing with the model is that that behavioral health care manager doesn't just have to give the family a list of options to call. They can
Sure.
actually help them with making sure that they're providing referrals that have the right participate with their insurance, that have availability, that reside in the same zip code or in the right place.
So is it fair to say that the behavioral health care manager will do some vetting, some
Yeah,
in their spare time anyway, um, looking for somebody who can offer DBT if they're not,
that's right.
certified or trained? Yeah.
Yes, and remember they can bill for that time, right? That's the real
Right.
beauty of this
Right.
model is that because they can bill for care coordination, even that non face to face time, as we like to think about it, that time that they're spending in care coordination, that is counted towards the minutes in these collaborative care billing codes.
Right. So, people listening to us may be thinking, gosh, I really want this for myself, for my husband, my mother, my
Mhm.
kids. Any just sort of practical advice then about how people can find uh, a primary care physician who's operating with a collaborative care model?
I'd
What are
start by
some
going to
ideas?
your own primary care physician and saying, "Hey, I heard about this collaborative care model.
Okay.
Do you have this in your practice?"
Okay.
I think that the more that patients are coming to the table and saying, "This is what we want to be in a place where we have both our mental health needs and our physical health needs cared for in the same place." I
Mhm.
think that really also motivates uptake of
Yeah.
the model as well. And so I think that's a really nice place to start is just asking your primary care physician. The other place oftentimes to reach out is sometimes academic health centers, right? The
Oh,
academic health center within your community.
okay.
Sometimes what we found in some of our implementation work is that some of these larger health systems or academic health systems, they may be more inclined to at least know about the collaborative care model and they may be closer to kind of really thinking about broad implementation.
That's a really great idea. So asking the front desk or your doctor when you're meeting with your doctor, or reaching out to a university, Department of Psychiatry, I guess.
Yes, and even the Department of Internal Medicine or family practice. We've really tried to create thoughtful tools and education about the collaborative care model. And so if you go onto the Meadows Institute landing page, which I am happy to share, then there is actually a collaborative care, lots of different technical assistance tools. There's a one pager that was designed to be a policy brief for collaborative care. And that could be a paper that you take with you to your next primary care appointment.
Is there anything that I haven't asked you about that you think would be useful or important to talk about?
When I reflect on the importance of this model for where we are right now as it relates to healthcare, one of the things we didn't talk about was how common mental health conditions and physical health conditions are. And so we know, for instance, say that an individual has heart disease, say that they've had a heart attack or they're in heart failure. Those individuals have a significantly higher risk of also having depression.
Yep.
And what we found is that treating the depression can significantly help with the treatment of other medical conditions.
Yep.
So we've been talking more and more about this emphasis on chronic illness and what is the cause of chronic illness, right? And part of this is also addressing where we are right now in terms of chronic illness management. If we can really be thoughtful about how we screen for common mental health conditions and more complex mental health conditions for individuals who have complex medical conditions, things like diabetes, high blood pressure, heart disease, then we can really start to think about all of these ways in which physical health and mental health intersect. And we can sort of start to move towards not even thinking of it as different aspects, but really saying, look, the brain is another organ in our body, just like
Right.
the heart, just like the liver. How do we really think about having our mental health care delivery system be as close to our physical health care delivery system as possible? We need to really think about how do we evaluate for depression, for anxiety, for schizophrenia, for bipolar disorder.
Or for substance use
Or
disorders.
substance use disorder. Exactly. So, how do we have just a regular screening be there, just as we would for any other complex medical condition? This is the time now where we should say, no child should die of mental illness. What do we need to do to really have a call to action to say that let's get all of our resources together, whether it's research, whether it's creating the right care navigation system, whether it's revamping primary care and revamping specialty care. Let's all come together to really think about how do we transform healthcare so that individuals aren't dying of mental illness.
Yeah, and erasing the idea that mental health conditions are not medical conditions, because they are.
Yes.
And the mortality rate, for various mental health conditions like depression, schizophrenia, bipolar disorder, the mortality rate by just suicide alone is higher than most forms of cancer. What I love about this model, there's a lot of things I love about this model, but one of them is early detection, getting people evaluated and in treatment early on is a lifesaver.
Yes, it absolutely is.
It's really a great pleasure to have you here and to learn. I learned a lot preparing for our interview and talking to you today. And I'm going to keep on learning. And I'm going to go to your website and I'm going to talk to my primary care physician about doing this, because she's already doing mental health screening.
I love that your primary care physician is already doing it, and kudos to her that she's really following kind of those guidelines with screening, and that's wonderful. I think everything that we can do to support primary care physicians, because they're doing so much right
They
now.
are.
So creating those systems of support for them, all about it.
Well, thank you for all that you're doing, and thank you for joining us today. I really appreciate it.
Thanks so much for the opportunity to be here.